Hello, and welcome to Conversations with Dr. Kohli. I'm your host, Dr. Payal Kohli. I'm an associate adjunct professor in the cardiology division at Duke University and founder and medical director of Cherry Creek Heart. And today I'm really excited to be joined by my colleague, Dr. Charlene Day, who's an associate professor of cardiovascular medicine and the director of translational research at the University of Pennsylvania. Incidentally, she's also the national PI of the Sonata HCM trial, which is a trial looking at sotagliflozin in hypertrophic cardiomyopathy. So I'm really excited to learn more about this and where this is taking the science. Welcome, Charlene.
Thank you so much, Dr. Kohli.
So it's, really been wonderful over the past few years to see the field of hypertrophic cardiomyopathy start to grow. For the first time ever, in the European guidelines, we now have the cardiac myosin inhibitors as a class 1 recommendation. So I feel like our sort of medical armamentarium for hypertrophic cardiomyopathy is starting to expand. But talk to me a little bit about how this trial came about and what the sort of scientific rationale was thinking about an SGLT1 and 2 inhibitor like sotagliflozin in a condition like hypertrophic cardiomyopathy.
Sure. Well, this trial has been a couple years in the making. I had some early discussions with Dr. Mike Davies and Dr. Craig Granovitz at Lexicon about the potential of efficacy of sotagliflozin in patients with HCM. And the idea came about because of the, very positive results from the SOLOIST and SCORE trial, showing very early divergence of the curves to reduce total cardiovascular death, heart failure hospitalizations, and urgent heart failure visits in patients either with heart failure with reduced or preserved ejection fraction, or in patients that have cardiac risk factors and diabetes. So, the really marked relative risk reduction in these populations was very promising because a lot of patients with HCM have heart failure. Most of them who have heart failure with preserved ejection fraction, and we don't really have a lot to treat. And the cardiac myosin inhibitors, while being very promising and we're very excited about them, their use is still limited to patients who have severe symptomatic outflow tract obstruction. And we don't yet know whether their benefit will extend to other patients. In some of the subgroup analysis from SCORED, you can see that the hazard ratio for benefit is greater with higher LV in patients with higher LV ejection fractions, which tends to be the HCM population. And then also in a post-hoc analysis, we found that patients who had left ventricular hypertrophy but did not have hypertension, presumably these are people who might have HCM that accidentally got in the trial, or were at least have similar physiologic features to HCM. They had about a 50% reduction in outcomes, which was very much in line with the overall population in the trial. So I think the clinical data are very strong to support the rationale for potentially extending the use of sotagliflozin to patients with HCM from those with heart failure more generally. The trial is going to enroll patients with both obstructive and non-obstructive HCM. The rationale for enrolling for patients with obstruction is that the potential benefit is independent of the outflow tract gradient. So it's possible that it could the gradient's not going to be necessarily relevant. Obviously, we're not going to enroll people who have very severe symptomatic obstruction, who need surgery, or are going to start a cardiac myosin inhibitor. But there are a lot of people with outflow obstruction who don't meet those criteria who may potentially benefit from sotagliflozin.
I'm really excited to see the results of this because I think hypertrophic cardiomyopathy is really one of those sort of ultimate phenotypes of heart failure where, as you pointed out, you have systolic hypercontractility, you have diastolic dysfunction. So studying this type of a class of drugs in that particular population, I think is fascinating. I also want to highlight that you said both obstructive and non-obstructive. So I want to ask you a little bit farther. Is it going to be all phenotypes, apical, outflow tract, reverse curve of HCM? And also, what are some of the clinical endpoints that you're going to be looking at? Are you going to look at things like BNP change as well as quality of life, or is it mainly going to be some of the harder endpoints such as cardiovascular death, heart failure, hospitalization?
Yeah, so it's a great question. So, like you said, I think, we are extending this as the eligibility criteria are very broad. So we are hoping to enroll most patients with HCM as long as they have the preserved ejection fraction. We're including patients who are on cardiac myosin inhibitors.
Great.
The only stipulation is that if there are myosin inhibitors, their EF has to be a little bit higher, just so we're not in a range where they might get discontinued. And also they still have to have some residual symptoms. So they have to have a a score on the KCCQ, or Kansas City Living with Heart Failure Questionnaire clinical summary score of 85 or lower. So we are looking for patients with some symptomatic limitations. But other than that, the eligibility criteria are extremely broad. Because we think, again, the mechanism of action, is going to be independent of a lot of these specific disease features like gradient and other things. As far as the outcomes, the primary endpoint is going to be change in KCCQ clinical summary score. And so a significant difference between groups would be what we would be looking for as a positive result. There are a lot of secondary endpoints that include, I mentioned BNP, different parameters on echocardiogram. There are other quality of life scores, that we'll be looking at as well. But we are not doing stress testing. We're not doing functional endpoints. I think because the trial got so large, it is 500 patients across 130 sites.
Wow.
In multiple countries. And so we're going to have, we decided to keep it, to really focus on what's important to patients, which is how they feel.
So talk to me a little bit about the doses that you're using of the drug in the trial, and then also the timeline. At what endpoint are you going to be doing evaluations of that quality of life assessment?
Yeah. So the study design of the trial is randomized, double-blind, 1-to-1. And they'll be on the drug for either drug or placebo for 26 weeks. The primary endpoint again is the KCCQ clinical summary score. The trial has started to enroll. We're in the process of site activation and screening patients, and so we're anticipating that we will have everybody completed the trial within 2 years. So that's the timeline we're looking at.
Wonderful. And what dose of the drug are you using? Are you trialing both doses or just one of the doses?
I forgot that part of the question. So 400 milligrams is what we're starting.
Okay. Yes.
Option to dose reduce if the patients have side effects.
Okay, great. Well, so I'm really excited. So it sounds like in a couple of years, we would at least have a sense of whether or not this is a completely sort of uncharted territory in terms of scientific question. This class of agents in hypertrophic cardiomyopathy has never really been looked at before with any endpoint. So I'm really excited to at least get quality of life data. Do you think this is going to set the stage if it is a positive trial for some of those larger outcomes trials? And do you see this medication being incorporated into your armamentarium for your HCM patients?
I do. I'm hoping the results will be positive. I think there are a lot of indicators that, both from similar populations of patients in which there has been efficacy. And, we also have some preclinical data that the mechanism of action, may be on cardiac metabolism, and there may be even some direct effects on the heart to reduce the work that the heart is doing, which would be favorable for HCM. So I think that, there's a lot of potential. And certainly, if the trial was positive, it would be very exciting to be able to incorporate another, medication into the guidelines for treating patients with HCM. We really have nothing that has any evidence for treating patients with non-obstructive HCM. We use beta blockers and calcium blockers. There are no clinical trials. There really is no evidence for those. And every trial that has tested other drugs for non-obstructive has not been successful at achieving efficacy. So, we'll see the cardiac myosin inhibitors are currently being tested for non-obstructive HCM in 2 clinical trials. But I think this, again, could be additive on top of those because I think the mechanism of action is different.
So before I let you go, Dr. Day, I just want to pick your brain. Do you think that an SGLT1 and 2 inhibitor would have any hemodynamic effects on a phenotype of obstructive hypertrophic cardiomyopathy? Obviously, we always worry about our preload reducers and such. So I'm just curious, in your clinical experience, what are your thoughts on how you think it might affect the degree of obstruction, if at all?
Yeah, it's a good question. We've had a lot of discussion around this, and we've incorporated an echocardiogram at a 4-week time point to look at that specifically. That's sort of one of the safety endpoints, is whether the patient's gradient increases or they develop obstruction if they didn't have it previously. We're not really anticipating because that's going to be an issue because the effects, the preload effects and the diuretic effects are fairly transient, and patients who aren't diabetic, they're not going to be losing a lot of glucose, so there's not going to be that osmotic, diuresis. So I think that if anything, it'll be transient and will probably resolve. If there is any hemodynamic effect, if anything, I think there may be a positive benefit from some of the preclinical data that we've acquired.
Well, I want to thank you, Dr. Day, for really pushing the frontier of science forward, because this is such a difficult disease to treat with such limited options. And so really bringing this type of research to the bedside for us is really such an incredible contribution. So thank you for leading this trial. And I know that I'm anxiously awaiting the results of it with bated breath. And I hope that it makes its way into the armamentarium for our patients with HCM. Thank you so much for your time today. And to our audience, thank you for listening in. Please do follow along the results of the Sonata trial, which hopefully should be out in the next couple of years. And do write in with any questions and comments. Until next time.